Thank you, Dr. Harrison. Thank you all on the panel. We appreciate your time and your words today. Again, I mentioned earlier that you have an opportunity to ask questions of the panel. Is there anybody who has a question that they'd like to share? David.
We hear about NPNs in women and various complications, but we never hear about men. So as a man, I'd like to ask, are there any differences in complications that we may experience versus the women?
Okay, so I was very careful to address that potential imbalance by showing you that as a man, you're probably more likely to present with PV or myelofibrosis, and you're slightly at a more risk of arterial thrombotic events. But I think that, Ruben, you probably have some data with regard to symptoms and gender differences. Might that be right?
I'd say there's a couple of things. One, a big one is regarding the issue of androgens. As we age, certainly having testosterone levels decrease, can be a part of aging, and it certainly can have a variety of negative effects. So there's been great interest in people having hormone replacement. In patients with MPNs, this could be potentially problematic, in that one, it certainly can increase the number of red blood cells. So in particular, in patients with PV and others, it could be a contraindication. Indeed, frequently it's a source of an increase in red cell count. So as we try to diagnose patients with PV, one of the common confounders is around patients that are on testosterone use. Sometimes that we know of, sometimes it's a medication people really try to keep somewhat close to their vest or somewhat hidden. So we have to sometimes, be very proactive in terms of identifying that. In terms of the symptom burden, I can't say that there is a specific symptom we see in men having worse, but being a man, we always feel things were much wimpier than women, so we probably feel them much worse.
That's because you're from Mars, right? Of course, we use androgens therapeutically as well in myelofibrosis, don't we?
Correct. So there's the full spectrum. So at the PV, potentially the ET end of the spectrum, androgens may be a negative. If you're JAK2 mutated ET, Lord only knows it may push the counts up too high. But on the other end of the spectrum, if we're too hypogonadal and we have myelofibrosis, it can worsen anemia. So we sometimes use it as therapy for anemia in myelofibrosis.
Thank you. I made a mistake in the beginning. I did not introduce myself. My name is Bill Crowley. I work with the MPN Research Foundation. Are there any other questions? Giora.
Well, as a CML patient, we know that CML was part of MPNs not long time ago. And I want to understand, because there was a talk by Ruben about basic biology of MPN. What prevents coming up with a magic bullet like imatinib or Gleevec or other TKIs that came up to CML for the other diseases of MPN?
It really is an excellent question. As we look at the approach taken in CML, there is an abnormal gene, we block the gene, we block the protein that's made, and the disease is better. This, in some ways, is a fantastic story in CML, and in other ways, in many other diseases like MPNs and other cancers, we found that CML is a bit of an exception, in that there's multiple genes potentially being affected in sequence or at different points. So as we try to inhibit JAK2, we find that there's no simple way to completely inhibit JAK2 or the mutant form. And if you do, it doesn't necessarily lead to a complete reversal of the disease. So in some ways, CML is one of the clearest pathways, and it's so dependent on a single step that it's really been that impactful. There have been multiple other diseases where that's been attempted, a few where there has been success, but in the majority, there has not been, and probably in part because there's more than one step. It's as if you have to, as opposed to a light switch, it's more like a code to a lock, where there's multiple things that have to occur at the same time.
Before we go too much further, I should have mentioned this earlier. When you ask a question, identify what group you were from. And the first question was from David Wallace. What organization? PB Reporter. Yeah. Okay. In the back here.
Yeah, good afternoon. My name is Susanna Leito from Novartis, but my question is because I have a relative with ET. And I was really surprised by the dichotomy of ET complication. So it could be thrombosis, but it could be also hemorrhage. And I was a little bit surprised by that because essential thrombocytopenia means a lot of platelets. So my idea was that the risk is more thrombotic. And the second question is about familiarity. I think, Dr. Meza, you mentioned that could be family clusters.
Yes, this is the apparent contradiction of platelet count in ET with the possibility to have thrombosis or bleeding. There is no any direct relationship between the degree of platelet increase and the appearance of the risk of appearance of thrombosis. So it doesn't mean that as higher you have the platelet count, you have a higher increase in risk of bleeding. On the contrary, as higher is the platelet count, for instance, more than 1 million, then you have an increase of bleeding, not of thrombosis. So these are clinical facts. And concerning the second point, the familial clustering, it has been related that approximately ET and PV patients have, yes, an approximately 5 to 7-fold higher risk of having a direct relative with this with MPN that may be not the same. So the patient may have ET and the relative PV or PMF or other MPN.
So it's better to check the children?
No, at all. These are not inherited diseases. So these are acquired diseases.
So just, this is something that I make sure that I mention to my patients, actually, especially young women who are thinking about having babies, because it's something that they sometimes will say, does my baby need to be tested as soon as it's born? So actually these are very rare conditions. So if you have 1 in 100,000, even if you have a 5 to 7-fold increase, the definition of a rare disease is 5 per 100,000. So what I say to my patients is their relative is more likely to be struck by lightning than to develop one of these conditions. And if you test, and Carlos's point was also that if you test children and they have a normal count and they don't have the JAK2 mutation, it doesn't mean they won't develop it later. But it's more about saying, if they happen to have a blood count, can somebody please make sure they look at it and make sure it's normal? Because one of the problems we often encounter is a patient may have had several blood counts before they get to us and they're abnormal. And the second thing is that if they have some unusual symptoms, so an increased risk tendency to migraine or pruritus, that they are tested then. I feel Ruben wants to make a comment.
Well, it's a good discussion because it's a confusing point and one that causes a lot of stress. And it gets to a little bit of the question that Chiara raised regarding the biology. Succinctly put, we think that there is probably some initial step in MPNs, and that a second step is this development of the JAK2 mutation CALR MPL. Families that have MPNs clustered within them probably have something wrong with this initial step. Because if we look at a family in which there's multiple affected members, maybe an uncle with P. vera, a nephew with myelofibrosis, they don't even necessarily have all the same mutation. One might have JAK2, one might have MPL. So this whole issue of why people develop MPNs may lead to this familial part. A couple of caveats I share with patients, in addition to everything that's been raised by Carlos and Claire, is one, family members. If there's a family with multiple confirmed cases, then we clearly are more suspicious. But people still have to acquire them. So we think there's probably 2 steps, and they typically do it as adults. So this is, again, not something that we run around and check 5-year-olds. But if there's multiple affected family members, I certainly have people at least be aware. in that I think depends a little bit on the family. Frequently what we get as well is we have one confirmed patient in front of us with an MPN, but they have an aunt that had something wrong with her blood, and I think they took blood off at one point. So as we get into the family history, it frequently can become unclear, was there really an MPN or not?
Yes, in this regard, when I make the history taking of a patient, I usually ask for relatives with excess of red blood cells, of platelets, or leukocytes. It's quite useful.
Okay, thank you.
Hello everyone, I'm Erez from the Flute of Light in Israel. My question is that I hear a lot about PMF patients that live with the illness for many years and don't get any treatment at all. But after so many years, the illness is beginning to gain progress, and only then they consider a bone marrow transplant. Why not do the transplant as soon as they see the PMF? Why wait until the patient is older with background illnesses and his survival rate is lower?
Okay. So you raise an excellent point. And this decision about moving to a transplant, which is still the only curative therapy that we have for any of these conditions, is a difficult one. And we must always balance the risks of the transplant against the risks of the disease. Also, as I talk to my patients, I reflect on the timeline that Carlos showed and think about the advances that we've made with newer drugs that help patients to live longer and better. And also at the same time, our colleagues in the transplantation field are advancing. Transplants are getting safer. Ultimately, a bone marrow transplant is a risky procedure, even for patients who have a transplant with low-risk disease, and it would be very rare to transplant a patient with low-risk disease, hardly ever now. The risk of a transplant would still incur 5 to 10% risk of mortality. So generally, the guidelines are that we would only transplant patients when their life expectancy is around 5 years or less. And it's because of this balancing up risks and benefits, and perhaps the optimistic hope that we have that a lot of the work that goes on in the field and in pharma and biotech, etc., will ultimately lead to a cure before the patient needs a transplant.
There are some statistical analysis that kind of confirm what Dr. Harrison has mentioned. There's some that are in development through the CIBMTR, which is kind of the global database of patients undergoing transplant, as well as some analysis through the EBMT with Professor Kroger, who's going to be on the program, I believe, tomorrow. And with that, we find that patients with low-risk myelofibrosis, probably have more to risk than gain. So at least in terms of statistical analysis, they're more likely to lose years of life than gain years of life when we balance everything out in terms of the risk. Patients with intermediate to and high risk, if a transplantation is a good option, they may be better off going for a transplant. Now, it's a very complicated discussion that we'll clearly get into greater detail tomorrow. Individuals with intermediate 1 are very much on the fence depending upon many, many factors. So much of the effort regarding to refine prognosis in the disease is somewhat in this group of patients. And again, if an individual is intermediate 1 with high-risk molecular features who's age 30, that may be very different than the 76-year-old that is intermediate 1. So there's a lot of factors that we consider.
Okay.
Just concerning this point, in Spain we have recently analyzed a registry of 800 myelofibrosis patients, and only less than 10% of all myelofibrosis patients went to transplantation. So this benefit only a small proportion of all myelofibrosis patients.
I'm Werner Zinkern from the German MPN network, and Dr. Bessis was talking about HU and the problem of causing leukemia later, maybe, yeah, if taking HU. That's a problem it's always talked about in the German groups, and especially in Munich, we have a regional group. And I would like to know more about it, the problem. Dr. Grieshammer, one of the German experts, told me, no, don't believe in it. It's clear it doesn't cause leukemia, yeah, HU. And Dr. Mesa, I saw some nice videos of you, and you are talking about you have a lot of patients who take it and with very good experience, and HU is a medication you have to take, you have to pull out under the wheels of the bus, you say, yeah? You are joking about it, for you know it makes problems, but you want to use it, I guess, yeah? In Germany, we have a saying, if you ask 2 lawyers, you get 3 opinions. Now we have 3 experts. We get 3 opinions now, and one of Professor Grieshammer, I guess. What do you think?
I would say that there's a lot of factors as we individualize the treatment. And I certainly stand by the comment that for certain patients, hydroxyurea can be a helpful therapy, but it depends on many factors. I'd say all of our therapies, I've had patients that have had spectacular results with, and each of them people have had difficulties. So it's very nuanced. I mean, the full list of drugs that we have for MPNs is clearly well less than 10. You know, and even drugs that we commonly use is really less than 5. You know, so we really try to maximize their use and their benefit. But it depends on many factors.
Most retrospective studies have shown a lack of correlation between the use of hydroxyurea and the appearance of acute leukemia in large cohorts of patients. And there is still a debate about if acute leukemia raises from the treatment that is therapy related to hydroxyurea or to another drug, or if it's a natural consequence of the disease. Because you know that the Swedish group, analyzing a very large cohort of patients, demonstrated that 25% of all MPN patients that has not received any cytoreductive therapy evolved to acute leukemia. So there is still a debate.
Okay, that's all the time we have for questions right now. I know I promised that if you wrote questions down, we would be able to get